See, once you place the implant, the day you place the implant, it will be 40 Newton. Okay, 40 or 50 Newton or 60 Newton. How much it will be on the second day? It will be 40. How much it will be on the third day? It will be 40. How much it will be on the fourth day?
Yes.
It will become less. Then less. Then less. Then less. It will hit a very, very less weak stability at one point. Around second week. Second week is the most dangerous period. Second and third week. Then after that, it slowly regains. In second to third month, it gets back to original stability. So that is why delayed loading means after 2 months or 3 months. Immediate loading means just finish all the work before 3 days. If you drag the procedure on 5th day, 6th day, the implant will be very less stable. You will disturb the implant. So better try to finish in 3 to 5 days. That is why they are telling 72 hours. They will see the clock. The moment you do the surgery, before 72 hours, they have to fix the metals acrylic bridge. But if you do welding on the first day itself, you don't worry about the time frame. You can relaxedly give the process on 10th day also, because the welding is holding the implants. That is one more advantage. So why from the 4th day it is decreasing? Because there is something called phagocytosis. They come to the picture and they resorb the bone, remodel the bone, a new bone is forming. So because of the phagocytosis effect, the implant is stability is coming. Okay. So where we use multi-unit, where we use single piece cement retain, you got a fair idea. C cases, complex cases we use, simple and advanced cases we can use single piece. You can use it in any, even if good bone is there, you can we use it, you can use it, but there is no need, this is enough. And where to use basal and where to use the compression. Where to use basal, where to use compression. This is the bone. Buccolingually there is good bone, height wise there is good bone. You can place a conventional implant or you can place a compressive implant single piece. But if there is no bone here, so there is a no bone here. Okay. There is no bone here. So I will place it basal. Even here, it will be only covered by gum. But I don't have to worry because it is a smooth surface. The gum will attach with the smooth surface. If you place a conventional implant here, then you have to place a bone graft and GBR. Either you can do like that, place a conventional implant, do a GBR, or if you want to avoid GBR, you can place a basal implant. Because the threads are only at the end, there is no threads here. That is the advantage, and it is not a rough surface. If it is a rough surface, then the bacteria from the oral cavity, it may contaminate plaque formation, calculus. But since it is a smooth surface, no plaque attachment. So in our practice, what implant we are using, compressive or basal? Almost 95% we are using compressive only. Very rarely we use basal. In full more cases, imagine if you see some situation like this, the teeth is like this. What we do is we do alveoplasty like, then we place a regular compressive. So since we do bone leveling procedure, we remove this single wall. It becomes a good bone, buccolingually good bone is it. So most of the time we use compressive. So where to use compressive, where to use basal, we understand. Wherever we can place a conventional implant, we can place a compressive. But the advantage is in compressive, it is available from 3 mm, 3.2 mm diameter. So that even if the bone is very less also, you can place a compressive. If one wall is missing, legally there is totally no bone. To avoid bone grafting conventional bone, we can place it. Okay. Yes. So 4 types: single piece, multi-unit. Here basal, here conventional, compression. Here basal, here compression. Okay. So this is simple and advanced cases. This is very complex cases. Here bone defect is present. It's a straightforward situation. Bone defects. Yes, sir. So before we start the patient, we have to understand. We have to get an idea whether it is simple, straightforward, or advanced or complex. Okay, this is upper jaw is a complex situation. Severe bone resorption is there. Lower is a simple situation. Even starting, we can do this, but upper is a complex situation. So we will see. So before seeing the X-ray, we have to see the clinical picture, extraoral picture. If you see, this is a kind of class 3 situation, mild class 3. Yeah, can you see? Yes. It is a mild class 3. So occlusion, prosthetics, we have to keep it in mind. So the mandible, you can see the class 3 incisal relation. So extraoral photos are mandatory if you are doing full mouth or upper anteriors aesthetics. Otherwise, patient may tell previously it was like that, it was changed like that. So for us also to evaluate, taking photographs is legally also is a must. And take a dynamic video also. We tell it as a dynamic video where the patient smiles and speaks. Tell them, encourage them to speak. So smile video, we get an idea about how much gums patient is showing. When smiling, how the lip moves, how much gum the patient shows. If the patient is showing more gum, then it becomes a little difficult situation. Here the patient is not showing any gum, so we don't have to worry. So this is 3/4 view. Oral pictures. The lower metal ceramic bridge is doing all the damage, right? See the crossbite on premolar molar also. So prosthetics will be a challenge. Now we will see the X-ray. So usually we used to see these kind of images, right? Panoramic. Most commonly we see this kind of images. We will do a tentative plan based on this panoramic first. So what we observe is, here there is severe resorption is there. Okay. You can see the canal 2 lines, right? You can fairly track 2 lines. And we can see the mental foramen here. Mental foramen is opening upward, but anterior also the mental foramen is shadows there. This is called yes, J hook or anterior loop of. Here also we can see we can track it. Some patients we cannot track it. The more osteoporotic the bone, it is difficult to track. Here also it goes like this. It may be an anterior loop or it may be the extension of the inferior canal anterior. This is called incisive canal. It travels anteriorly, small way. Or it may be the hook of mental. Here till the apex, beyond the apex there is bone loss. Here mental foramen is there. Here very less bone available here. Here we should do some bone leveling. Okay, each and every bone is at different level. So some bone leveling after extraction we have to do. Here there is bone loss till the canal. So after extraction, avoid curating or do gentle curating, otherwise we may injure the nerve. So this is the general planning. So what is the implant planning? So we are planning for first to decide whether you are going for a single piece or a multi-unit. It's a straightforward situation from my point of view. So we are planning for single piece. Okay. So how many implants totally for mandible? Usually we go for 6. Sometimes we go for 6. Mostly we go for 8. Sometimes we go for 6. If the distal mandible is good, we go for 6. If the distal mandible is not good, we put 2 implants in mandible. So anteriorly, this is the interforamina, this is the mental foramina. This area is called interforamina area. This is called interforamina area. This is a very key area where we place 2 implants on this side, 2 implants on this side. So interforamina, 4 implants. Molar 1, 2, totally 6 implants. If molar area is not good, we put 2 molar, totally becomes 8. Okay. So either it is all on 6 or all on 8. So 1 molar, 4 interforamina, total becomes 6. If the distal mandible is poor, we give more support. See, if the soil is not strong, we give more pillars. So 2 for the safety. Yes. So almost most of the time we place 8 because the bone is not good. So now we will first finish the interforamina planning. So where is the foramen opens? Mostly it will be near the second premolar. Right? So can we place an implant after extraction straight away in the second premolar? It is quite risky because the mental foramen is. If you feel steady, you can stand and stretch, no problem. No. You can stand here also. No, it is very free. Because sitting a long time. No. So placing implant in the second premolar itself is quite risky because the mental foramen opens there. Can we place a second premolar implant? Yes, first premolar. It is safer. In conventional, what they are doing is they are starting the implant from second premolar, but they are angulating it mesially. Right? If you are starting from second premolar, you have to angle it mesially. Otherwise, if you tell no, I am a beginner, I cannot angle and all, better place a straight away first premolar. Okay, and you leave the canine. Don't place anything in the canine. Just mesial to the canine in this 4 to 3 2 area. Place 1 1 We'll draw. First premolar, in front of canine, totally 4 implants. This is a very simple basic plan. So you are placing the implants axially, not very much tilted from second premolar. Okay. After learning, we can try tilted also, like all on foot conventional. But if you place tilted, you have to bend it. Whenever you are placing tilted, you have to bend it. If the bone is very smooth, bending is not possible. Right? So before starting a case, what you do is see the bone quality, whether it is osteoporotic. If the bone is osteoporotic, place the implant as much as axial because you cannot bend very much. The bone quality is good, you can place implant in some other direction and maybe. So here our tentative plan is 2 first premolar implant, 2 lateral incisor implant in the interforamen. Tentative plan. In the molar, what to do? Definitely you cannot place implant in the 8. The distal root of 7 also not ideal place because it is close to the defective area. Okay. Either you can place 1 implant here or 1 implant here. See, you have a lot of options here. There are basically 2 techniques. Either you can place implant in the root extracted socket, or you can place implant in the interroot area or interdental area. So either the distal implant, the distal most implant should be in the distal root or away from the distal. Okay, to avoid cantilever. Our aim is to give only till 6, not 7. So that means either you can place one implant here, the interdental bone, which is good, or place in the socket. That we can decide in the CBC. But tentatively, one implant either here or either here. So another implant where it will come? It can come either here or in the interdental area. Anywhere you can place. Okay. Basically, you have to place 2 implants. That's it. Lot of options are there. Okay. Either you can choose here and choose this interdental bone. Okay. Because second premolar better to avoid because of mental foramen. Okay. Or place one implant in the mesial root and one implant in the interdental area. If you place one in the mesial root and one in the distal root, the implants may be too close to each other. So we should respect some inter-implant distance also. A proper spread also should be there.